Hello, everyone, and welcome to today's session. My name is Marta Borkowska, and I'm an ICU nurse working at Ghent University Hospital in Belgium. I will be your moderator for today. Our special guest is Chris Branker. Chris is a clinical nurse specialist for the Neuro ICU at St. George's Hospital in London. Chris has published multiple journal articles, and contributed to several textbooks. So if you'd like to, you can look him up afterwards. For the following hour, Chris will give us some insights into the management of raised intracranial pressure. But before we begin, please notice that there is a question section down below. And it is available if you have any questions to raise them and to give us some comments on the presentation. The questions will be answered and debated afterwards at the end of the presentation. So please try to make an advantage of it. Okay, I will no longer keep you waiting. Chris, the floor is all yours. Enjoy the presentation.
Thank you, Marta. Good afternoon, everybody. I'm Chris Branker. I'm from St. George's Hospital in Southwest London. What we're looking at today is the management of raised intracranial pressure. Right. Okay. I just wanted to show you the two hospitals that Marta and I come from. Neither is particularly attractive, but I think it's worth noting that Marta lives in Ghent, which is one of the most beautiful cities in Northern Europe, and they still managed to put up a building that ugly, so well done to them. So what is the basis of intracranial pressure? Well, the skull is a rigid box, and it has only one significant opening at its base, which is the foramen magnum. And the skull is completely filled by its contents. There are no spaces within the skull. The brain and meninges make up 80 to 85% of the contents, blood vessels about 10%, and CSF between 5 and 10%. The skull is slightly overfilled in normal circumstances, so there's a low internal pressure, the intracranial pressure. And the normal range for that in someone lying down is about 7 to 15 millimeters mercury. It tends to be a little bit higher if you're upright. The principle is very straightforward. If one of those skull's contents gets bigger, then one of the others must shrink, or the pressure will go up. It's effectively the principle of the overfull suitcase. So there is a limited capacity to absorb change by shunting CSF down into the spinal column and by compressing the blood vessels. And this is referred to as compliance. But once this compliance is exhausted, the pressure will rise in an accelerating upward curve. This is described as the Monro-Kelly hypothesis after the two surgeons who first demonstrated it. So essentially, if you look at the curve, as intracranial volume starts to increase, you get an accelerating upward curve of pressure. And what this means clinically is that when you're on the upper slopes of that curve, the steeper slopes of that curve, small changes in intracranial content will make for quite big changes in intracranial pressure. So what causes raised intracranial pressure? Well, an increase in the size of the brain or the meningeal volume. So tumors, abscesses, cerebral edema. Here we see a patient who has quite a large right parietal meningioma. So that's a tumor growing out from the dura. And it's surrounded, as brain tumors typically are, by a sort of a belt of edema. Here we see a situation where the brain, in fact, has expanded itself because of generalized cerebral swelling caused by an hypoxic brain injury. Note that the sulcal effacement, so you can't see very much of the wrinkles of the normal appearance of the brain, and there's a loss of gray-white differentiation. All of that tissue is the same color. Well, excess CSF will also produce a rise in ICP, so that can happen from overproduction of cerebrospinal fluid, which is rare and associated with certain tumors. Underabsorption of CSF is much more common, particularly as a response to subarachnoid hemorrhage, for instance. And blocked circulation can also happen. There can be a number of causes for this: tumors growing to block the aqueducts, congenital hydrocephalus is typically a problem of a blocked circulation. In this particular scan, we see very badly dilated ventricles caused by an arachnoid cyst, a colloid cyst blocking the circulation. Hematomas. Blood vessels don't tend to occupy more space in any given circumstance, but if blood gets out of the blood vessels and forms a hematoma, that will occupy space and create a raise in pressure. So this could be traumatic or non-traumatic. Here in this scan, you see quite a large right intracerebral hematoma. So it's a non-traumatic hematoma that's caused by high blood pressure. Here we see two scans of trauma patients. The scan on the left shows a traumatic extradural hematoma. Blood here is trapped between the skull and the dura, so it has that very neat encapsulated appearance, like a bow curve. But you can also see on that scan that there is midline shift, there is pressure moving from right to left. As you can see, the ventricle on the right has been pushed towards the midline. The scan on the right is a much more severe injury. This is an acute subdural hematoma. Here the blood is under the dura, between the dura and the brain surface, so it follows the contours of the brain. It's a lot less neat in its appearance than the extradural hematoma. What we see here is a very large acute subdural hematoma with resulting very, very high pressure. You can see a massive shift from right to left on this scan. You can see that you can no longer see any sulci at all, and you can see very little gray-white differentiation. So this is a very, very bad looking scan altogether. It's worth remembering that foreign bodies can also penetrate the skull, and they will occupy space which they shouldn't be doing. Here we see a scan of a man who drove through a fence, and a piece of fence post basically penetrated the front of his skull and the left frontal lobe. So why does raised intracranial pressure matter? Well, you've got to consider cerebral hemodynamics. In the normal circumstances, the brain adjusts pressure and flow of blood to maintain a constant cerebral perfusion regardless of the systemic blood pressure. So this is called cerebral autoregulation, and it's why you don't faint every time you sit up. And this functions very well within quite wide ranges of systemic blood pressure. So in the normal individual, a mean between 50 and 150 will see no change in cerebral blood flow. The problem is that in an acute brain injury, this autoregulation can be impaired or lost completely. And from this point on, cerebral perfusion depends directly on the mean arterial pressure. In other words, the arterial pressure has to overcome the resistance of the intracranial pressure. So there's a simple equation: cerebral perfusion pressure equals mean arterial pressure minus intracranial pressure. In effect, the blood vessels are being compressed by the high ICP, and perfusion is then lost. In acute brain injury, a cerebral perfusion pressure of 60 millimeters mercury is regarded as minimum to prevent secondary ischemia. It's worth remembering that that doesn't actually follow in people who do not have a brain injury. So what we're looking for is to try and avoid that secondary ischemia, and the concept of primary damage in penumbral area is important here. The area that has been damaged directly by the force that caused the brain injury, let's say that fence post coming into the skull, that's damaged. We're not going to be able to do anything about the damage to that area. But that area will be surrounded by a penumbral area where there is potentially viable tissue, but tissue that is vulnerable because the perfusion to it is poor. And that poor perfusion is worsened when you have global rising intracranial pressure. So our attempts to try and salvage the patient very much are about trying to salvage that penumbral area, as much of that vulnerable tissue as we can. If you don't control ICP, you can find yourself very quickly in a vicious circle. High ICP leads to reduced perfusion. That leads to increased ischemia. Ischemic tissue swells, which creates more raises in ICP, which reduces perfusion, more ischemia, etc. And if you don't interrupt that cycle, if you don't stop that cycle, the patient will cone. What happens in coning is that you have grossly dilated, grossly swollen cerebral hemispheres above the level of the tentorium. And these are a much higher pressure than the space under the tentorium where the brainstem and the cerebellum are. And that area is still at higher pressure than the spinal canal, which is under much lower pressure than the whole system. So you have high pressure pushing down onto low pressure. And what will happen eventually is that these cerebral hemispheres will push down through the tentorium and squash the brainstem. And that will kill the patient in effect. If you do autopsies, postmortem exams on patients who have coned, you may well find bits of cerebellar tissue at the base of the spinal canal. They have basically been shot down there by the force of the brain coning. Signs of raised ICP in the early stages: worsening headache, vomiting, and you may get worsening focal neurology. So there may be increasing limb weakness on one side, there may be aphasia or other focal signs of rising ICP. Later on, you'll get deterioration in conscious level. There may or may not be seizures. And eventually you'll have one or more fixed dilated pupil. The very late clinical signs in critically high ICP are a very low Glasgow Coma Scale, bilateral fixed and dilated pupils. By the time you develop the Cushing's triad, in effect, the patient is coning, and that is your very last chance of salvaging the patient, perhaps. The Cushing's triad is severe hypertension, bradycardia, and Cheyne-Stokes breathing caused by loss of blood flow to the brainstem structures. So, initial management of the patient who has or may have a high ICP. This section is essentially aimed at care in the emergency department and perhaps in the general intensive care setting while you're awaiting transfer to a specialist area. So it's about how to try and minimize damage when you don't have intracranial pressure monitoring available to you. Our overriding aim here is to preserve cerebral oxygenation and prevent secondary ischemia. So airway. Poor conscious level means airway compromise. You should intubate the patient, and you should always sedate and paralyze the patient to intubate them in this circumstance. If the patient has a summed GCS of 8 or less, if the GCS is low and fluctuating, if there are seizures, if there are already signs of airway compromise, and you should always consider that if you're going to transport your patient somewhere, that you should be more willing to intubate them, even if they don't fit those parameters, because what you don't want to do is have to intubate them in transport. Breathing, we're aiming for a normal to high level of oxygenation, so a PO2 of 10 kilopascals or above, and we're aiming for a normal to lowish carbon dioxide level, so 4.5 to 5.0 kilopascals. Remember that carbon dioxide is a cerebral vasodilator. So hypoventilation in these patients will lead to vasodilation, and that will bring up the ICP. Hyperventilation will lead to vasoconstriction, and although that will reduce the ICP, it is at the cost of reduced perfusion and increased secondary ischemia, and is to be avoided. Circulation, well, we're aiming to maintain cerebral perfusion, and you're looking here for a mean arterial pressure of 85 or above. Obviously, this is assuming that you're not guided by an ICP monitor and making the broad, rough assumption that the patient's ICP may be high, so it may perhaps be in the early to mid-20s, and therefore that a mean arterial pressure of 85, 90 will be offsetting that. So you want to stop hemorrhage, you need to correct hypovolemia. If inotropes are necessary, and they probably will be, the first line is noradrenaline. Vasopressin and dobutamine can also be used. As soon as possible, you should start advanced hemodynamic monitoring so that your vasopressor use can be guided by adequate information. Keeping hemoglobin above 100 grams per liter to the normal to high end of things is generally regarded as being a good idea. The evidence base for this is not particularly great. You certainly want to correct arrhythmias if you have them, and you want to correct electrolyte imbalances. Disability, obviously we're aiming here to prevent secondary cerebral injury, and detection of that is very, very important. So you want, as far as possible, to be able to monitor the GCS, pupils, and limb movements. Now, obviously, if the patient is very heavily sedated, monitoring the GCS becomes effectively impossible, but you certainly want to keep a close eye on those pupils. If there is evidence, either clinically or from CT scanning, of raised intracranial pressure, patients should be given some osmotic diuresis. That's mannitol or hypertonic saline. If the patient is intubated, then they should be sedated in this early stage to unresponsiveness, so they don't respond to painful stimulus. Get a CT head as soon as possible. This is the best guide to immediate management of these patients by far. You want to maintain a normal blood sugar, and particularly you want to avoid hypoglycemia because that damages brains. Test for alcohol and toxins. Obviously, many patients with an acute brain injury will be drunk. Exposure, make sure that you examine for other injuries or abnormalities. It is, really, you're going to be fighting an uphill battle if you don't correct bleeding in other areas. Maintain normothermia, so you don't want the patient to be either hypothermic or pyrexial. You should be careful about active rewarming in shocked patients because you can just crash the blood pressure. Catheterize the patient and try and get some idea of their previous history. So now we're going to have a look at monitoring ICP and other parameters. ICP monitoring can be done in two ways in effect. The gold standard method is generally regarded as extraventricular drainage. And what happens here is a catheter is placed in a lateral ventricle via a burr hole, and it's attached to a drainage set. This doesn't have to be monitored or transduced for ICP, but it can be. And that will allow you to monitor the ICP and also to drain CSF if you need to reduce ICP. There is a slight potential problem with this method if the ventricles are squashed flat by very high ICP. So if you remember those two scans of the traumatic extradural and subdural I showed you, then you would never get an EVD into that patient with that very bad acute subdural because there simply isn't enough CSF space to do it. ICP bolts are the other main way of measuring ICP, and these are monitors that are placed into the outer layer of brain tissue via small holes drilled into the skull. There are two main types, the fiber optic, which is made by Camino, and the strain gauge type, which is made by Codman. They have their advantages and disadvantages. Here we see a picture of a patient with an EVD. So a burr hole is drilled into the skull, and the catheter is then placed through the burr hole, through the brain, into the ventricle, and then is connected to the drainage set. This is generally done in the operating theatre rather than on ward. ICP monitors, I'm showing you a Camino because that's the type we use, but the Codman are basically very similar. This is done by drilling a much smaller hole than a burr hole, typically into the right frontal lobe, and a retaining bolt is then screwed in. You pierce the dura with a needle, you pass the probe through the bolt and the dura, resting just inside the brain tissue. That's connected to a monitor, a dedicated monitor, and then that monitor is connected to your ICU monitoring, which will allow you to see the waveform, the ICP, and the cerebral perfusion pressure. I should say that incidentally that you can put one of these monitors in under local anesthetic. You can actually do it on fully awake people if you need to. ICP waveforms are worth having a quick look at. There are three waves in an ICP waveform. P1 is the percussion wave, which is the arterial pulse. The P2 is the echo of that arterial pulse off the brain structures. And the P3 is the dicrotic wave, the arterial dicrotic wave. As intracranial contents expand, they become less compliant, less elastic. So what happens there is that the P2 wave, the echo wave, starts to elevate. Essentially, it's like a tightened drum. And this happens before ICP starts to rise. So this is very useful clinically, because if you have a patient with an apparently normal ICP, but signs of poor compliance on your ICP waveform, then you would be much more reluctant, for instance, to de-escalate your ICP management. It would not be a good time to stop sedating this patient, for instance, because ICP will go up very quickly. As the pressure rises, the waveform becomes taller and steeper, and the P2 actually becomes taller than the P1 wave. So ICP and cerebral perfusion pressure monitoring allows us to target management to those parameters. If you use an EVD rather than the bolts, you can also actively reduce ICP by draining CSF, and even very small amounts of CSF drainage will reduce ICP quite significantly. That's because of the if you're on the upper parts of the curve, the Monro-Kelly curve, very small changes in content make for big changes in pressure. The limitation for ICP monitoring is that it is a global figure, so it doesn't represent necessarily what's happening at the site of damage. We're just getting a one size, one number fits everything kind of approach. A step up from that is brain tissue oxygenation monitoring. And that allows you to titrate your therapy to target basically the brain tissue oxygen level, the PbTO2, partial pressure of brain tissue oxygen. That means that you can manipulate the ICP, the FiO2, the mean arterial pressure, and the hemoglobin to give yourself the desired PbTO2, which should be somewhere between 20 and 25 millimeters mercury. Lycox make a brain tissue oxygenation monitor, but the one I'm showing you is made by Raumedic. This is the one that we use. It shows ICP, brain tissue oxygen, and brain temperature in a single monitor. You can see from the picture there that this is a patient who has an apparently normal ICP of about 11.3. And the brain temperature is roughly normal, 37.2, but the oxygen level is low at 16.4. So you would want to do something to correct that, regardless of the ICP. Cerebral tissue microdialysis is also available. Here, a microdialysis catheter is placed into the brain tissue. And ideally, you place it in the penumbral tissue, that tissue that you're most interested in salvaging. This essentially measures glucose, lactate pyruvate ratio, glycerol and glutamate, and these demonstrate the local cerebral metabolism, specifically whether you have hypoxia or ischemia. And you can target your therapy to what's happening at a metabolic level in the most vulnerable tissue. The slight wrinkle on this is that it's not always physically possible to insert the catheter in the area of the most interest, simply because, for instance, if it's at the back of the skull, you can't really have the patient lying on top of the thing. ICU management. What we're aiming to do here is to prevent the brain from herniating and to prevent secondary ischemia. So we want to control the ICP. We're aiming for an ICP of 22 millimeters mercury or less. We're aiming to optimize cerebral perfusion pressure. So we're looking for a perfusion pressure of 60 to 70 millimeters mercury. And we want to reduce cerebral oxygen demand. Obviously, the idea here is that tissue that has poor perfusion should be encouraged to do less rather than more, so it uses less oxygen. Surgical approaches to reducing ICP basically depend on having something to evacuate. So we have two scans here of the same patient, pre-op and post-op. On the left, you can see an acute subdural hematoma with midline shift. It's pushing right to left. So there's significant raised ICP for this patient. The scan on the right shows the same patient post-operatively. So the skull has been cut away, the hematoma has been evacuated, bleeding has been stopped, and the skull has been replaced. So you can see immediately that the structures are much more symmetrical. The pressure has been reduced considerably by the surgery. Craniotomy is one approach. Craniectomy is another approach. In a craniectomy, the bone flap is replaced at the end of surgery. Here we see two really horrible scans, frankly, from the same patient. On the left-hand scan, the patient has had a craniotomy. So as before, as in the previous scans I showed you before, but unfortunately the patient did not improve with the craniotomy. In fact, the patient still had fixed dilated pupils post-operatively. So they went back to surgery and they basically did a bifrontal craniectomy, taking bone flaps from both frontal skull, both sides of the frontal skull. Now, craniectomy will reduce ICP for the simple reason that the brain can herniate out through the craniectomy defect rather than pressing against the side of the skull. So this will improve the cerebral perfusion. And what the evidence shows us is that if we do decompressive craniectomy, more patients will survive. But there is still some controversy about the quality of survival in those patients. In other words, you may have more patients surviving with very severe disability. The medical approach to reducing intracranial pressure, well, we're trying to reduce or control the size of the intracranial contents in various ways. So we can make the brain smaller by reducing its water content by using osmotic diuretics, mannitol or hypertonic saline. And you want to try and maintain a high serum sodium content, so at least 140 that should be millimoles per liter, not millimeters per liter, sorry about that. The idea here being that you want as little fluid to leak out of the blood vessels into the tissues as possible. Reducing cerebral venous volume is really a very straightforward matter of keeping the patient sitting up. So an elevation of the head of the bed, 15 to 30 degrees, and the head and neck being in alignment so that the jugular veins basically are patent and drain well, is the simplest way of achieving this. You also want to control the interthoracic pressure so that blood drains easily out of the head and isn't subject to back pressure from the interthoracic cavity. So this is about your ventilation strategies, minimizing intrathoracic pressure, avoiding too much coughing, for instance. At the same time, we want to try and control the cerebral arterial diameter as well. Now, this is done with ventilation. Hypercapnia, vasodilation, means raised ICP, so that's to be avoided. At the same time, hypocapnia, vasoconstriction, cerebral ischemia, you want to avoid that. So we're aiming, in the first instance, for a CO2 of 4.5 to 5 kilopascals, low normal. It is possible to ventilate the patient a bit harder and go for 4.0 to 4.5, but that should really only be done while you are working out a better approach. So do it for short periods at most. Reducing CSF volume is possible if you have an external ventricular drain. That is not always, that very much depends on the surgeon's preference. Pain and agitation both make ICP go up, so sedation and analgesia are very important. And obviously, it is important to promote compliance with the endotracheal tube and the ventilator because a coughing, a bucking, gagging patient is going to have a high ICP. So again, sedation and analgesia. It is important to recognize and accept that essential nursing care is going to raise the ICP, and that's unavoidable. You do need to turn and reposition your patient periodically. You do need to do chest physiotherapy and suction, and these are going to make the ICP go up. So it's important to plan your care so that you minimize the effect of that. Bundle the care together so you've reduced the number of episodes where this happens. Make sure you plan the care and everyone involved in the care to minimize the duration of it. There's nothing more frustrating than turning a patient with a high ICP to find that the nurse looking after the patient hasn't bothered to get the clean sheet that she needed to put under the patient, and there's a delay. So make sure that everything is to hand so that you don't waste time. It is probably a good idea in most situations, but it depends on the individual situation, to give a pre-care sedation bolus. Get your care done and sit the patient up as soon as possible. If the ICP will tolerate side lying, and you can only find that out by experience, then do it. It is better to have the patient turning side to side than sitting on their backside all of the time, but it very much depends on whether the ICP is affected by that. Some patients it is, and some patients it isn't. Now, to improve cerebral perfusion pressure, you need to titrate your mean arterial pressure to try and achieve a CPP of 60 to 70. Normovolemia, noradrenaline, advanced hemodynamic monitoring. If we're measuring cerebral perfusion pressure, we have to keep the arterial transducer leveled to the tragus of the ear, which is the point of the third ventricle, rather than to the heart. This is because we're interested in the pressure of blood as it enters the skull. Okay. You want to maintain a PO2 of greater than 10 kilopascals, as already discussed. Keep a hemoglobin of greater than 100 grams per liter. And you should also try and restrict head elevation to a maximum of 45 degrees. It's actually quite difficult to get patients higher than that in a bed, to be honest. But if by the time you are higher than 45 degrees, you're losing cerebral perfusion. Reducing cerebral oxygen demand is extremely important. You want to try and make sure that the brain is doing as little as possible so that it doesn't become ischemic in a situation of poor oxygen supply. Sedation and analgesia are the easiest way, effectively, of reducing cerebral activity and thus oxygen requirement. All patients should be on an opiate. We use fentanyl. Morphine is acceptable. Propofol is our sedation of choice, really because it is easily reversed as much as anything. If we are getting towards the maximum dosage on propofol, we will add in midazolam. Midazolam is slower to wean, so we avoid it if we can. If you're giving high levels of propofol, particularly over days, make sure that you check lipids because you want to avoid propofol infusion syndrome. Barbiturates can be used to control ICP, but there is poor evidence of benefit to outcome, and there is a lot of evidence of complications and problems using barbiturates. So it is very much seen as a last gasp treatment. Seizure prophylaxis may or may not be indicated. There are a number of factors involved here. If the patient has had seizures or there are evidence of seizures, certainly those should be treated. Depending whether it is a good idea to give seizure prophylaxis to all of these patients, regardless, is somewhat controversial. Pyrexia damages brains. Sorry, I'll say that again. Pyrexia worsens outcome in acute brain injury. It damages the vulnerable brain. So you want to avoid it. You want to use antipyretic medication. If that doesn't work, either intravascular cooling or surface cooling, so as to control that temperature. Avoiding pyrexia is important, but hypothermia does not necessarily do the patient any good. There have been many, many research projects on this over many, many years, and the principle seems sound that if you induce hypothermia, you are reducing the cerebral metabolic demand, therefore you are protecting the brain from ischemia. The problem is that there have been no evidence that this actually benefits the patients in terms of outcome, and there is more and more evidence that it causes very significant complications which actually result in worse outcomes, so it is to be avoided. Hypoglycemia damages the vulnerable brain, so it should be avoided. There is some evidence that so-called tight control of blood sugar benefits outcomes. It's not very conclusive evidence at this point. And there is always the risk that if you overly aggressively try to control hyperglycemia, you will end up with hypoglycemia by accident. So it is generally thought that it is better to have a relatively lax control of blood sugar. So keeping the blood sugar under 10 is good enough. Obviously, we want to try and reduce complications as we possibly can. Many of these patients will get a healthcare-acquired pneumonia. Many of them will have aspirated at the time of their injury. They are vulnerable patients. They are very, very likely to get a chest infection. That doesn't mean we should be careless about trying to prevent further infections. DVT, obviously, that is a problem for patients who are deliberately immobilized in bed for potentially days. But you should only use low molecular weight heparin when the neurosurgeon says it's all right to do so. Obviously, if you have active bleeding inside the skull, you do not want to be giving dalteparin. Pressure ulcers, they may be difficult to avoid if you have the patient sat up in the bed at 30 degrees with very little movement for days at a time. If that's essential to control the ICP, then, well, you just have to live with it. But as far as possible, we should avoid getting pressure ulcers if we can. Stress ulcers, gastric ulcers should be avoided. Proton pump inhibitors are regarded as the drug of choice here, rather than H2 receptor antagonists. Try and promote normal joint and limb movement or prevent contractures by doing basic physiotherapy, a little bit of passive limb movements with patients. And something that is often not appreciated is the extent to which patients in this situation become hypersensitive to touch, particularly on their face and on the soles of their feet. Normally we touch our faces and we have pressure on our feet for an awful lot of the day. And if that stimulus is not there, those areas can become very hypersensitive. So a little bit of massage of the face and the soles of the feet will be of great benefit to patients further down the line. In terms of reducing complications and managing ICP, there is no question that early spinal clearance is hugely beneficial. You cannot realistically manage raised ICP on a patient who is being kept flat in the bed and log rolled. So the sooner that you can get that spine cleared, the better. Early feeding is essential. Acute brain injury is associated with increased energy expenditure. It's generally regarded that you burn through about 4,000 calories a day in the first few days after an acquired brain injury. Early feeding is hugely beneficial, but if the patient hasn't been fed for a couple of days, beware refeeding. There is some evidence that higher mortality is associated with a failure to reach full calorific requirement by day 7. How you feed the patient? Well, nasogastric route should be avoided unless the neurosurgeon has told you that the skull base is clear. Orogastric tubes are preferable if you are in any doubt. Psychological care is very important and shouldn't be ignored. Remember that we're talking about people who have become very seriously ill very, very suddenly. Somebody went out that morning and they were perfectly fine, and then in the blink of an eye, they're in intensive care, hooked up to every monitor under the sun, and with a very real risk that they are going to die. So this is a very sudden, very dramatically life-changing event for everybody involved. Nothing will be the same again after this injury. There is likely to be loss of earnings, a loss of career potential. Even in patients who do well by our standards, will typically not be able to go back to the jobs they held before. Some patients will become dependent on those around them for the long term. And this can mean a change in family and social roles. And this can effectively rip through an entire family. And many patients will emerge from an acquired brain injury with a change in personality. They won't really be the same person they were before. And that adds a huge amount of stress to everybody involved. Now, some of these effects of brain injury are not apparent to families immediately after the injury at the time where they're in intensive care. And I'm not suggesting that you go around and frighten the life out of your patients' families by discussing all of this when they're at their most vulnerable. But certainly as the patient stabilizes and it looks as though they are going to survive the injury, some discussion needs to be had that they are not going to return quickly or even possibly at all to where they were before. So finishing a little bit earlier than I thought I would, but I'd like to thank Johannes Mellinghoff, who is the senior lecturer here at Kingston University in St. George's, for his help with this. And I think both Marta and I would like to thank Sareen, who has made all this actually possible logistically, and has been very reassuring in the approach and run up to this event. So thank you very much for listening. And I would say that is my email address if you want to get in touch and ask me any further questions. But I will now hand back to Marta, who may have some questions for me, I think.
Hello there, Chris. Thank you very much for this clear and interesting presentation. And indeed, we have some questions already coming in, quite many. So maybe it's not so bad that you have finished a little bit earlier. Let's move on to this question section. The first question that has been raised is what is the target of the CPP in pediatric patients? Would you know that?
I must admit, I'm not an expert in any way on the management of pediatric patients. They have very, very different hemodynamics in the injured brain to adults. So as my understanding is, and you really should not take this very, very seriously because I'm not an expert in this at all, is that they tolerate lower cerebral perfusion pressures, but that is something I confess I'm in no way properly informed on. So congratulations, first question, caught me out, don't know.
Okay. Further, somebody's asking how much coughing would increase the intracranial pressure.
Okay, coughing always increases intracranial pressure. If you imagine, almost everybody's had the situation where they've had a coughing fit and they cough and they cough and they cough. And after a while, your eyes start to hurt. And that's because coughing brings up the intrathoracic pressure. It stops blood draining effectively from your skull because there are no valves in that part of the circulation. So after a while, your ICP goes up and your eyes hurt because that puts up your interocular pressure. Now, in the normal person, that's perfectly fine. You stop coughing, the ICP goes down, the eyes stop hurting. But someone who's got a high ICP already, someone who's on the upper slopes of that curve, then coughing is going to make the ICP rise dramatically. So you want to avoid coughing unless you are actually actively managing it with physiotherapy. So you do need to keep those lungs clear. There's no point in getting a patient, filling up with chest secretions because you can't oxygenate them properly, and you cannot then oxygenate the brain properly. So you do need to actively manage that, and that will mean sometimes lying the patient down. It will mean doing chest compression with them. It will mean making them cough if necessary. You have to do that. You have to try and manage the ICP before that with a little bit of bolus of sedation, and then after that by sitting the patient up and possibly changing again your sedation to offset that rise in ICP. You have to grit your teeth and get on with it.
I totally agree with you. That's more or less the same that we use, how we treat our patient. And yeah, as you said, coughing is, yeah, sometimes it has to happen. And if it's not, if the patient's condition is severe enough, then the patient should be sedated and even sometimes paralyzed to maintain low intracranial pressures.
I think paralysis will not directly change your intracranial pressure because it doesn't have any effect on that. But it's important to remember that if you have someone coughing a great deal or bucking on the tube and you can't control that with sedation, then paralysis in the short term is necessary. It's not ideal because it means there are lots of problems associated with it. But yes, sometimes you're just going to have to paralyze that patient. If you're going to move the patient, for instance, to scan, then definitely you have to paralyze them because you want to avoid coughing or bucking on the tube as you move the patient.
About paralyzing the patient, Erica has raised an interesting question. If the patient is sedated and paralyzed, how can I know if the patient has seizures?
Okay, you can't really. I mean, one of the difficulties with a heavily sedated patient is that seizures then become very difficult to detect. Now, there are centers, certainly, that practice continuous EEG monitoring. And one of the things that comes out from that is many more patients are having subclinical seizures than we actually account for. The problem with continuous EEG monitoring is who is reading the EEG, because they're very difficult to interpret. And the number of people who are competent to interpret them is probably never enough to actually provide an adequate service, if you like. And unless you're actually looking at the EEG at the point where the seizure happens, you're just looking at a lot of lines on a screen. Something that we are looking to develop more directly, but it is difficult to do, to be honest. But if in effect, if you have a very heavily sedated patient, you can't see clinical signs of seizures. You may see something on EEG, but even that will be suppressed by the sedation.
Exactly. Without further ado, I'm going to ask another question because there are lots of questions to answer for you. Also, Erica has asked how to make a 5% natrium chloride solution because they don't have it in her hospital.
I put 5% therein because that's the version of hypertonic saline we use. 3% saline is also available. I think 1.8% is available, but you need to give quite large volumes of it, and that's probably not what you want to do. So certainly some centers use the 3%. So if that's what's available, then go with that. In terms of how you make it, off the top of my head, I wouldn't know, but you could use strong sodium chloride solution injected into a bag of saline. You'd have to work out the arithmetic of it, but certainly we've done that in the past, but now we have pre-prepared 5% saline, I'm glad to say.
That's the advantage of working in an Eastern European country, right?
Yeah, oh yeah.
Also, Erica would like to know how much of CSF, cerebral spinal fluid, should be drained. How much should be drained? Yeah.
I mean, that's very much going to depend. I think if you're using that method of ICP monitoring where you can drain CSF by that, then it's really very much that you drain a couple of mils and see what the effect is, and then then repeat it as necessary, or as much as the surgeon is willing to try in effect. There can be problems with the EVDs in patients with high ICPs because sometimes they block because effectively the ventricle is squashed flat. So they don't actually drain very well, or you even get brain tissue coming up through them, which is always a bit disturbing, I have to say, but it does happen.
Certainly a little bit disturbing. Would you say that zero PEEP could be a strategy to reduce intracranial pressure, high intracranial?
PEEP, when I started in neuro long ago, it was always held that PEEP was something you should try and reduce in these patients because it basically the idea is lower PEEP means lower intrathoracic pressure, means lower ICP. The effect of reducing the PEEP to zero has not been shown to have a really good, clear impact on the ICP. It doesn't sort of change stepwise. And obviously by reducing PEEP, you are significantly raising the risk of secondary infection effect. You're going to get sort of collapse of the alveoli and so on. So we would generally run our patients on a PEEP of 5 rather than anything higher. They generally tolerate that. But there's no point in reducing ICP at the cost of oxygenation, in effect, because you end up with an ischemic brain.
Yeah, I agree. Another question is about mannitol. Sonia is wondering if it's still indicated. Is there any good evidence about it?
So the question, there are 2 ways of looking at that question. First of all, do osmotic diuretics actually help? And the second version of the question is mannitol preferable to hypertonic saline or the other way around? Evidence for almost everything that we do in traumatic brain injury is difficult to establish just because it's a highly complex situation and it is difficult to randomize patients effectively. And it is also difficult to monitor and measure outcome in a way that is to actually shows you clearly whether something is a benefit or not. Using osmotic diuretics will reduce the ICP in the short term. There is some evidence of what's called a rebound effect after you stop giving the mannitol, but the ICP then jumps back up again. But if a targeted strategy of keeping serum sodium on the high side, serum osmolarity on the high side, is effective in controlling ICP. It's one of many things that you're going to have to do. We tend to use 5% saline in preference to mannitol because it gives you a more predictable effect on the serum sodium level and the serum osmolarity. Therefore, you know what you're doing better than using mannitol.
Yeah. Okay. Thank you. Could you tell us, please, what drugs, what medication do you use to sedate patients continuously and to give some bolus doses? Okay,
so we use propofol and fentanyl as our primary sedation strategy. Mm-hmm. If the patient is on rising levels of propofol, we will then add midazolam. You might also consider using some clonidine, but that would usually generally be further down the line. But so in the early stages, it's going to be propofol plus fentanyl plus or minus midazolam. And we would use those drugs to bolus the patient, in effect. Now, obviously, every time you bolus a patient, you take the risk that the blood pressure will fall. So you might get a drop in ICP, but you might get a drop in blood pressure as well. And it's really very much about finding out what works for your patient, because some patients seem to be more sensitive to this than others. So you have to, unfortunately, just basically try it and see. But that's how we would do it, yeah.
It's a calculated risk, isn't it? We use propofol and remifentanil as short working agents. Yeah. And if it's necessary, we switch to midazolam, and sometimes if it's prolonged, also morphine. But yes, it really depends on the case.
Yeah.
It's not just really straightforward.
Yes, I mean, morphine's perfectly acceptable. Fentanyl and remifentanil are generally thought to have a shorter acting effect, but midazolam and morphine is a common and perfectly acceptable.
Okay. Another question is, are you using tranexamic acid in the setting of severe head injury?
That's generally, yes, generally it's given in the ED, yes. Yeah.
Another question is, what substances do you use for preventing seizures? Is there an indication for routine use of muscle relaxants? So actually 2 questions. Right, so I'll talk about the seizures. Yeah. Sorry, about the seizures first.
it's slightly controversial as to whether you should give all of these patients prophylactic anti-medication. If there have been seizures or witnessed seizures, then certainly, obviously, you must go ahead and give that. So, depending on the nature of the lesion and the site of the lesion, the surgeons may, want seizure prophylaxis in patients. They may decide against seizure prophylaxis in other patients. If you're going to give seizure prophylaxis, it should be short term and then tapered off, particularly as you wake the patient up and you can see whether there are actually any seizures. Our drug of choice, first line nowadays, is levetiracetam, Keppra. Yeah, I think phenytoin is still, I think, quite widely used, but it has a rather unpleasant side effect profile. So generally, we're going with Keppra these days. You're the same, are you, Marta? Hello?
Yeah. Hello?
No, sorry. So would you?
I've lost you. Sorry.
Sorry, I just stopped talking. I know it's unusual.
Okay. So the other part of the question was about muscles relaxants, but I believe you have already answered that a little bit in your presentation and afterwards.
If by muscle relaxants people mean, the questioner means neuromuscular blockade, then I think I've answered that one.
Yeah, I believe so.
Using, say, benzodiazepines like lorazepam or diazepam. If you have an acute seizure, then you may want to use lorazepam to control that seizure while you work out what to do next. But beyond that, I don't think there's any good indication for using, using lorazepam or diazepam prophylactically, in the same way that you might with other patients.
Another further question is again about pediatrics. Are there any guidelines on management of raised intracranial pressure?
I'm sorry.
Aware of this?
You're going to have to Google that one yourself. I'm afraid I just don't know anything about the pediatric side of things. Sorry.
Yeah, me neither. I can't help it. I can't help you to answer that question. So.
Yeah.
Okay, thank you. Another question. It's still not done. It's actually a question that you have already answered. Which one is the best osmotic therapy to reduce raised intracranial pressure, mannitol or hyperosmotic natrium chloride? So
yeah, I mean, hypertonic saline is probably preferable. The good thing about mannitol is that it is much easier to give, particularly in kind of the in-field. 5% saline, you've got to be fairly cautious about how it's administered. It's better done through a central line, for instance. So mannitol is we still see people using mannitol as a rescue therapy, and that's perfectly fine. Yeah. I think definitive management, hypertonic saline is better.
We also use mannitol from time to time. It really depends on the case.
Yes.
I would say rescue medication, but for instance, in patients with very elevated salt level in blood,
yes.
blood. So it might be also another yes. possibility if you.
That's a very good point. Yes. By the time you're getting, if you're getting sodium levels into the 150s, you're starting to think, maybe we've exhausted this particular method.
Yeah. Okay. What do you think of barbiturate coma and mannitol use in reducing intracranial pressure? So I think mannitol use you have already answered a couple of times, but what about barbiturate coma?
So barbiturate coma, what was the other half of the question? Barbiturate coma and?
Yeah, and mannitol use in reducing intracranial pressure. So.
Barbiturate coma, it certainly used to be a much more prevalent therapy. It was often seen as the alternative to using decompressive craniectomy in patients with refractory raised ICP. Mm-hmm. So when you failed on your first line and second line management, you go for surgery or you go for barbiturate coma. The evidence for the effectiveness of barbiturate coma isn't particularly good. Short term, yes, it'll bring that ICP down nicely, but in terms of the long-term outcomes for the patients, it may not be doing them any favors. there are many disadvantages to using barbiturates, not least of which is the fact that you won't be able to assess the patient neurologically for days once you've started it, because it takes such a long time to wear off. But there are also associated problems with blood pressure management. They're not nice drugs to use in that sense. So that is something I don't think we've done it for quite a while now. We still keep it as in our, if you like, in our back pockets in case we can think of nothing else to do with the patient and we've run out of other options. But it's something that we're keen to avoid as far as we possibly can. But a lot will also depend on what the other treatment and monitoring possibilities are where you work. If you don't perhaps have ICP monitoring, but you are aware that the patient has a very high ICP from CT scanning, if neurosurgery may not be available to do a decompressive craniectomy, although it's not practiced in that particular area, then going for the barbiturate coma may seem to be the only thing that you can do. Sometimes you have to make the best of what you've got, rather than regretting the fact that you don't have something better.
Yes, we have also left behind barbiturate coma. It's been years that I've used this medication. So yeah, okay. Another question is what is the best sedation for patients with raised intracranial pressure with low Glasgow Coma Scale? I don't know, low Glasgow Coma Scale at the beginning, or
yeah, well, somebody with raised intracranial pressure is probably going to have a low Glasgow Coma Scale. I mean, we talked about sedation. We generally would use propofol and an opiate as a first line approach, because it's relatively short acting, relatively easily reversed. We would add midazolam if the ICP remains high. So that would be our general approach. Yeah.
I have another interesting question. Is it possible to sedate the patient with anaconda, volat anesthetics, ketamine with low doses?
Ketamine, ketamine has been used. We have used ketamine. One of our clinicians was quite fond of ketamine. None of the others were particularly keen on it. I think they felt that some of the problems of using ketamine outweighed any benefits from it. But it's certainly a drug of it's an option. Not as a first line, but perhaps as a second or even third line.
There was another, there was also anaconda and volat anesthetics mentioned. Are you aware of use of anaconda?
Anaconda is, I'm sorry, I don't know, I'm not aware of that. Sorry, what is that?
It's for volat anesthetics, and maybe I could help you with that. I actually don't know what the research says about it. I've experienced one patient with anaconda. We don't use it very much at the hospital. It's for very narrow. So in the intensive care, we basically don't use anaconda, right? But at this one particular case, we needed it because the patient had severe bleeding, subarachnoid to be precise, right. And she was also pregnant. So this is a very limited group of the patients, I would say. But that was this one particular patient, and she was just fine with anaconda. But I don't know actually any statistics, any numbers, any recommendations. So it's just based on my own experience.
Okay, thank you. I'll have to go and look that up, because it's something I don't know anything about.
Anesthetics, yeah.
I mean, certainly using anesthetics. I mean, it's not something that we would consider in the intensive care, generally at all. Pregnant patients are obviously very difficult to manage for obvious reasons. That does make your options much more limited, certainly.
Yes. Yeah. I'm aware there are volat anesthetics available for management of patients with raised intracranial pressure, but I'm unable to give you any more information. I wouldn't like to. I wouldn't like to lie or just give it from the top of my head. So let's move on maybe to the next question. Is there any role of furosemide in ICP reduction?
Well, it's a loop diuretic, and it can achieve a certain amount of reduction in effectively you're going to be raising the serum osmolarity by drying the patient out a little bit. It's generally felt that the osmotic diuretics are better for doing this because they have a more direct effect on the tissue content. But furosemide as an additive may well be considered. You'd have to look at the urine output, I think, there as well. If you've got a patient who doesn't have a good enough urine output, then you would certainly want to use furosemide, I think.
Okay, thank you. Another question is about neuromuscular blocking agents. Erica asks if there are any, or maybe what kind of those agents would you use to paralyze the patient?
Well, we would use, if we have to, we would use atracurium. For this. We try and avoid using it as much as we possibly can. The situations in which you might find yourself using it are possibly, when you have a patient who's coughing and bucking on the ventilator, but really there you're looking to see whether your sedation should be improved. One situation where you might find yourself using it is if you are cooling a patient to try and control pyrexia, particularly if you're using surface cooling, the patient may shiver. And shivering is not good. So you may find yourself using it there. Beyond that, we would just use it when we're transporting patients to scan, for instance. But atracurium is what we would normally suggest using for that. Short boluses of rocuronium, for instance, might well also be another alternative. Yeah,
okay, thank you. Another question on the subject is how aggressively do you treat partial O2? And what strategies do you use? Sorry, not brain tissue oxygenation, I believe.
Brain tissue oxygenation, right. Well, if you have brain tissue oxygenation monitoring, then, if you put the monitor in, it's because you're going to treat that parameter. So then yes, you are going to be aggressive about this. You're going to look and see what you can change to bring that brain tissue oxygenation level up. So you're going to look at the simplest thing, obviously, is the FiO2, but you also want to look at the ICP and the CPP. Sometimes by bringing the cerebral perfusion pressure up slightly, by increasing your vasopressors, you can improve the brain tissue oxygenation. Sometimes you might find that bringing the blood pressure up a little higher may actually offset that and make it worse. So you have to try and get the balance right. But looking beyond that, looking at, for instance, improving the hemoglobin, so your oxygen delivery is better, your carrying capacity is better, therefore your delivery is better, is also quite useful. So I personally, my view of it is that it is a beneficial way of managing these patients. I appreciate that the evidence, as so often, is a little ambivalent about it as to whether it actually results in a clinical improvement in more patients. But I think the more information that you have, the better, I think.
Okay. We're almost at the end, Chris, the question section. The last question is, what is the best way to monitor intracranial pressure when you haven't got one, you don't have any monitoring in place? Yeah. How would you manage it?
There's really very little way that you can do it indirectly. They were going back, a long time. Lots of people who have tried various non-invasive methods for measuring intracranial pressure, for instance, such as looking at intraocular pressure. Mm-hmm. So, if you go to the opticians and they do the test, where they puff up air into your eye, then you can do that, and you can construe from that what the intracranial pressure is doing. None of these have actually, as far as I know, developed into a kind of a usable clinical tool that has actually gone into widespread use. Unfortunately, if you don't have intracranial pressure monitoring, direct intracranial pressure monitoring, you can only go on the clinical signs. And the difficulty there is that if you sedate the patient relatively heavily, then all you've got to go on are the pupils. And by the time one of the pupils dilates and fixes, you're pretty far down the line, basically. That's kind of your last warning before everything goes wrong. So, ideally, these patients do need to be monitored so that you can actually treat them appropriately before you're too late. But it's very difficult.
Yeah, I agree.
These are not patients in whom you can do a lumbar puncture, because you'll kill them if you do that. With expanding mass lesions in the skull, if you open up a channel of low pressure at the bottom of the spinal column, they will come. So can't do that.
Okay. I believe we came to the end of the questions, of this extensive list of questions. If there are no further questions, Chris, do you have anything to add? Maybe.
There were some fantastic questions. I'm really, really impressed by that, and it's great that people are engaged. It's fantastic. I appreciate that.
Yeah, I'm really pleased with the number of questions, to be honest.
Yeah.
So thank you very much, everybody, for your questions. And thank you, Chris, for sharing your expertise and your knowledge in such an interesting and clear way with us. And I hope it's not the last time we hear from you, to be honest.
Okay, that's very kind of you to say. Thank you, Marta. I'd happily try and do this again.
Yeah. But wait a second, before we round up, there are a couple of things I should mention here. So there were also already 2 questions about that. But I would like to remind you that the recording together with the presentation will be available shortly after this webinar in the online support room, together with the quiz, with the webinar quiz. You'll also receive an invitation to a short satisfaction questionnaire, and we would love you to fill it in, because we value your feedback very much, and we strive for continuous improvement of our educational programs. So please, if you could help us in this way, please do it. And last but not least, I would like to invite you to our next webinar. It will take place on the 6th of October, and our next speaker will cover the NIHP contribution to sepsis. You will also receive the link to register for that webinar. This will happen in the following days. I believe we came to the end of this webinar. Thank you for joining us. Thank you, Chris.
Thank you.
For your speech. It's a pity it lasted just for 1 hour. Actually, we're over 1 hour already. I hope you enjoyed this experience as much as we did. Thank you very much, and enjoy the rest of your day.
Thank you.